So I hope you are all in a great phase. This is a pretty good evening. Yesterday, you all gave your INICET exam. Now it's time for a recall. So I'm Dr. SJK. I'm the ENT faculty for you. So I'm going to discuss November ENT recall session for this INICET. I hope you would be very happy. You would be in a bit of delicate position how things have panned out. Few just I'm going to go through these questions which may be useful for me in the upcoming NEET exams. You may belong to any category like I told you before. Please listen to this recall. It will be of huge importance for you. So first we'll start with the topic distribution which was asked in the concluded INICET exam. We had topics ear, nose, throat, out of which pharynx and larynx. We had totally 7 questions. Okay, we had one more question, so which was bit between anatomy and ENT. So I excluded that. So totally we had 8 questions. So I excluded one question. So it's 7 questions. So out of the 7 questions, we have 3 from ear, 2 from nose, one each from pharynx and larynx. So we were talking about this during our hackathon sessions and all. So there used to be a trend that majority of the questions will be asked from ear, but that trend was changing for the last 2 years. They were asking a lot of questions from nose, but again they have gone back to the older trend where they will be asking more questions from ear. So this exam, more questions were asked from ear. So keep that in mind. I will always used to tell, please revise the previous year question, previous year topics. That's it. We can't always go by our gut feeling that last 2 years, this is the weightage topic. No, include all the last 5 years. Okay. So after concluding that all the 5 years topics have been covered only, you could confidently approach the exam. So we'll start discussion. So as we Adoplexus had workbook, so 5 questions were directly asked from the workbook, 2 questions indirectly on the workbook. So almost we are covering all the questions that are supposed to be asked in INICET as well as NEET exam. The first question, 65 adult coming with the hearing loss over the high frequency region. Which part of cochlea is affected? This is a direct repeat questions 2 years back from the INICET. So here is a cochlea. We are having a cochlea which is having a coiled cochlea which is 2 3/4 cochlea. So we are having apex base. So out of which the base is meant for high frequency sound, apex meant for low frequency sounds. So it's an easy question. High frequency loss, the answer is base. If it is low frequency loss, the answer would be apex. Next question from here. It's a newer question. They asked, what is the marked region? So they have asked this particular region, entry point to the temporal bone. So the entry point to the temporal bone, they have asked the temporal bone axial cut. The answer for this question is internal auditory canal or internal auditory meatus. So what about other options? So this bigger air shadow is the external auditory canal. So carotid canal, see here, if you're having a spine like this, so in this spine, this is jugular. This is carotid. So these are 2 canals. Okay. And also if you're having cochlea, so we'll be having cochlear aqueduct somewhere over here, which is not evident in this particular cut. Remember, this is a single cut. In the single cut, we may not see all the structures. So that is not seen here. So you just look over here. So this is axial and sagittal sections, which was given in our workbook. So in our workbook, we have clearly depicted malleus stapes, ice cube bone appearance. We have depicted mastered axial system and also how cholesteatoma will erode the structures. And also we had clearly given it is internal auditory meatus. Okay, fine. So this question, if you have applied it well, if you could able to identify structures that you have already learned in the imaging, you could have answered it very, very easier. Next question. Which of the following is not done in infants? So this was a repeat indirect question from the previous INICET. Previous INICET, they asked the question, if OA is not done in neonate, what is the other option? The answer for that particular question was free field audiometry. Bera was not given at that time. Here, the question is very simple, not done in infants. So which of these tests can be done in infants? First, OAE screening test, Bera confirmatory test, free field audiometry. What is a free field audiometry? We will keep a speaker like this and will give sound signals. If the child is reacting to the sound signals emitted from the speaker, we will plot it as pass. So in this way, we'll keep on increasing the sound stimulus through a speaker kept in front of the child. So this is called free field audiometry. Why? Because the child will not allow us to place the headphones. So placing the headphones, placing the bone probe is not easier. So it is very difficult to do these two cumbersome process for performing pure tone audiometry. So this is a pure tone audiometry. See, keeping the headphones, keeping the bone conduction probe to a child, that too in a soundproof room, is very, very tedious. So pure tone audiometry is normally done after 5 years of age. So before that, it is free field audiometry. The answer for this question is pure tone audiometry or audiogram, whatever they would have given in the exam. So pure tone audiometry is the answer. Free field audiometry can be in case of a neonate or an infant. Next one, moving on to nose. So this is a new question. Which nerve is blocked by this procedure? Which nerve is blocked by this procedure? So this we haven't given directly in our workbook, but I have told you this a number of times. Behind the maxillary sinus, we were having pterygopalatine fossa. This is a very important fossa considering the extent of tumors such as juvenile nasopharyngeal angiofibroma and then CA nasopharynx. So it's very, 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 very important. So this pterygopalatine fossa will communicate with the nasal cavity through sphenopalatine foramen. Communicate with the infratemporal fossa through pterygomaxillary fissure. This was exactly taken from our workbook. So I have told you this will communicate inferiorly through a foramen called greater palatine foramen. Though I haven't mentioned the greater palatine nerve, but this foramen I've told you in class, greater palatine foramen communicate oral cavity with that of the pterygopalatine fossa found behind the maxillary sinus lateral to the nasal cavity. So the pterygopalatine fossa will be having pterygopalatine ganglion. So from this pterygopalatine ganglion, we will be having greater palatine nerve. So this greater palatine nerve will come and reach the maxillary tuberosity, a foramen near maxillary tuberosity. So if we bend our needle like this and we could inject the anesthetizing agent into this foramen, that will be a beautiful local anesthetic block for doing nose procedures. We could do FESS septoplasty even in local anesthesia. For that, we need two local blocks. One is the greater palatine block. The answer for this question is greater palatine block. The second one is sphenopalatine block. For this, the landmark is behind middle turbinate. Behind middle turbinate. So these are two local blocks that can be given for doing nose procedures. That can be given for nose procedures. So that explains the greater palatine block. Arrange the steps of FESS. So we had uncinectomy, bullectomy, open maxillary ostium, ethmoidectomy. So this I was telling right from the day one. We had steps in FESS, which is very important. Exact same picture taken from our workbook. So steps involved in FESS is uncinectomy, middle meatal antrostomy, ethmoidectomy, sphenodectomy, frontal recess opening. In this, ethmoidectomy involves bulla, which is also part of ethmoid group of hair cells. So bullectomy is the first ethmoid cell which is opened. Then the other anti-ethmoid cells will be opened. Then the posterior ethmoid cells will be opened. So between the middle metal antrostomy and ethmoidectomy, we'll be having bullectomy. Okay, so this is the order. So after that, we could either do this or do that. If the patient is not having frontal sinus pathology, we don't have to do frontal recess opening. We just have to do sphenotomy. If the patient is not having sphenoid open involvement, we don't have to open that. So depending upon the extent of the disease, we could design our procedure. But the first basic steps such as uncinectomy, middle metal androstomy, ectotomy is common for all FESS procedures. So the answer for this question is we start with uncinectomy, open maxillary ostium, bullectomy, and then ethmorectomy. So this is how I explain it. The answer for this question is A, C, B, D. A, C, B, D. So the next question is a question from pharynx, a bit of anatomy oriented question. So a patient which is having dysphagia dysarthria, which of the following structures are associated except? So in simple words, the structures are involved in speech production as well as swallowing. So what swallowing? We are having three phases of swallowing: pharyngeal phase, then esophageal phase, then oral phase. So for oral and pharyngeal phase, which of these structures are necessary? Which of the following structures is not necessary? So getting into it, genioglossus, a part of tongue, absolutely necessary. Posterior pharyngeal wall, soft palate, which will close with each other and create a tight chamber. So that is absolutely necessary both for speech production as well as swallowing. So the nasopharynx has absolutely nothing to do with speech or swallowing. The answer for this question is pretty easy, is nasopharynx. So this we did not cover directly, whereas we explained indirectly in our workbook: nasopharynx, oropharynx, and laryngopharynx. Okay, fine. Last question is, patient came with carcinoma larynx. This is OG question. They were not asking questions from CA larynx for the last 2 years, INICET, but they have gone back to the old scenario of asking questions from CA larynx staging. Previously, there used to be at least one question from CA larynx staging. Now they have gone back to the same settings. So this question is a tricky question. CA larynx involvement of true vocal cord and anterior commissure. Till this, it's very easy. You might think that it is T3. So there is also involvement of inner thyroid cortex. Inner thyroid cortex comes under T3 or T4A. The answer is T3. So if it is complete involvement of thyroid cartilage causing pericarditis only, it is T4A. So in this question, it is clearly T3. It is not T4A. So we'll get back to the staging. See here. So T1A is limited to one vocal cord. T1B is limited to both vocal cords, but it is superficial involvement, not fixity. T2 either superior or inferior spread with impaired vocal cord mobility, that is not fixity. T3 limited to larynx with vocal cord fixation, invasion of paraglottic space, or very important, look over here, inner cortex of thyroid cartilage. Okay. T4A involves outer cortex of thyroid cartilage, beyond larynx, deep extrinsic muscles of tongue, strap muscles, thyroid or esophagus. So if it is outside the premises of the larynx, it is T4A. Within the premises, that is till the inner cortex of thyroid cartilage, it is T4A. So why it is very important? Because T3 means you could try chemoradiation. You could preserve the voice. Then if recurrent, go for total laryngectomy. So T4A cannot preserve voice. So go for total laryngectomy followed by post-op RT. Okay, so this is how it works. So CA larynx, I know would have been a bit confused about T3, T4A. So it's a clear-cut case of T3. Okay, so what we are repeatedly telling is factual questions, PYQs, PYTs, everything they're asking, but everything conceptual. So if you are very confident that I am confident on the structure, for example, they ask internal auditory meatus. I hope most of the faculties in India would have not explained that, but still, you can have that application skills if you're very clear with the anatomy, clear with the radiology, so how things are working out. So trust in yourself, believe in yourself if you're going to crack such questions and such examinations. So my best wishes, keep learning. That's how it works. Thank you.